I spoke a lot yesterday. Hopefully, a lot of you guys were in the big room. But these are my credentials. This is what I guess gives me the authority to stand up here and speak. The big ones being the last three, excuse me. Just that I've lived in the direct primary care experience kind of since 2016 when I founded my clinic, helped found the Direct Primary Care Alliance, and then from that have migrated on to work with Sesame, which is an online online marketplace for transparently priced healthcare services. So that's kind of my background. We do have learning objectives because you always have to have them, I guess. But essentially, I'm going to run through this real quick because I think it's actually important to talk about a little bit about the evolution of where we've been when it comes to policy, health insurance, and the history of like this evolution. I feel like a lot of this is a snowball that got rolling downhill and collected a lot of debris, and now we have not just a snowball, but like the fur from under the couch and like discarded hair and all this other gross stuff that is in this huge mess that we call health insurance and healthcare. And it all started about in 1929, or at least this is kind of our accepted beginning of health insurance, which incidentally is also when penicillin was invented. So perhaps it was like, oh, we invented something, now we can actually use it, and okay, we should design an insurance product, or the beginnings of one to start using it. But the Texas school teachers banded together in about 1921 to prepay for medical services, and they were prepaying a specific hospital at the time. So it wasn't necessarily an insurance product, but we would kind of think of that as like a premium to if you looked at it today. In the 1930s, different groups of employers in different sectors, and so this I thought was interesting, like lumber and mining, so careers that were intimately involved with getting hurt, caught on to this concept, and they started to include some outpatient care and doctor services as part of their prepayment bundle. The group that started in 1929 would eventually become essentially Blue Cross, and the outpatient group in the 1930s would become Blue Shield. So that was sort of the beginning of Blue Cross Blue Shield. Much of the evolution surrounding the economics of healthcare in the US is actually a consequence of these downstream unintended effects. These war-related policy changes are often cited actually as the most impactful moves that firmly tied our healthcare delivery to the employer situation, which actually diverges wildly from every other every other kind of Western country as they develop their insurance systems. So in 1942, the War and Labor Board instituted wage and price freezes, and then in 1943, they clarified that any contributions to insurance or pensions actually did not count towards wages. Then, in 1954, the IRS clarified that employers' contributions to health plans were considered tax deductible as a business expense. So this is kind of where we started to really see like what became the health insurance industry. And by this time, even in the 50s, health insurance was like maturing as an industry, and they were starting to use all the things that we hate kind of as consumers of healthcare, like risk stratification, benefit management, kind of benefit changes, utilization review, and things like that. So it was when they couldn't raise wages. So in the 40s to 50s, kind of in the post-war period, the wage freezes essentially meant that in order to sort of enhance the benefit package that they were providing to their employees, that they were like, well, okay, so we can't pay you more, but what about this really awesome like healthcare benefit that we have? And at the time, it was actually pretty affordable, right? It wasn't what we pay today. But it cemented it in, it gave a tax protection, it became kind of what we expect as US consumers of healthcare. So, welcome. And then, of course, the 60s, Medicare, Medicaid, passed in 1965. And while there wasn't really a lot of change in the 70s, the decade was actually marked by essentially just this increasing like rumbling of, I think we're spending too much, we're spending more, et cetera. And so kind of thinking about the actual cost of healthcare. The 1980s saw several notable laws. EMTALA is the law that requires that if you end up in an emergency room, you have to be taken care of regardless of ability to pay. And then COBRA, I think we're all kind of familiar with, where you can access the employer health insurance package up to 18 months after your termination. And then the 1980s also saw kind of a little smattering of expansion into providing care for children and providing care to pregnant women and things like that. And then 1990s brought in a lot more changes to healthcare. So HIPAA was passed in 1996. And given that we often focus on like the privacy aspect of this law, it also actually expanded access by, not to the extent that the Affordable Care Act did later, but it did protect some pre-existing conditions. And so it actually expanded access to care as well. S-CHIP expanded coverage for children by essentially adjusting the income barrier lower. Or essentially you could qualify having a higher income, excuse me. And then we also could see that Medicare Plus Choice came about in the late 90s. It was later called Medicare Advantage, so this is kind of the beginning of Medicare Advantage. And so I think what's missed when you kind of do a high-level policy look at like what was happening in the background, all these private companies in the 90s to try and contain costs. And I think, how many of you guys are physicians in here? I recognize a ton of faces, yeah. So the 90s was HMO time. And so that is like also happening in the background, is like this idea that we're gonna control costs by using the HMO model, which I think we all know how that turned out. Medicare Part D in 2006. And then of course in 2010, the Affordable Care Act was signed into law and kind of was enacted over the following years. So kind of as I described, as all of these policy changes and all of these unintended consequences rolled down the hill and gathered up all the stuff, especially in primary care, there was a growing movement of people who just did not tolerate this, did not want to work in this environment. And so the idea of going back to a cash pay model started to take hold. So this is almost 100 years, about 80 years after like the initial sort of the Baylor teachers that did the collaborative for the hospital in 1929. So almost 100 years later, this pendulum has swung so far that we have primary care doctors being like, all right, let's go back to, let's see if we can figure out a cash pay model, right? So the direct primary care clinic kind of arose in different parts of the country. There's a lot of quibbling. If you ever get drinks with a bunch of DPC doctors about like who invented it and like where it started and all that stuff, that's fine. I'm not gonna go through that today. But I do want to just highlight that there is an actual definition that was published in the literature back in 2015. This is by Dr. Phil Eskew, who hopefully everybody's kind of familiar with. I always describe him as a masochist because he has his JD, MBA, and DO as well. Like he spent way more time in school than is reasonable. But anyway, he was actually at the Graham Center and came up with this. So a DPC practice must be a primary care practice that, number one, charges a periodic fee for services. Number two, does not bill any third parties on a fee-for-service basis. Number three, any per-visit charges are less than the monthly equivalent of the periodic fee. That last one's a little bit of a mouthful, but essentially means that if you're gonna charge something like a copay, it's gonna be less than like your monthly fee, right? So if you charge $50 a month, your copay per visit should be less than 50. This one, I think, is where a lot of the tension, this definition is where a lot of the tension comes from that a few different speakers have brought up over the last day, in that this is where a lot of the DPC doctors get hung up on sort of that purist mentality of like, well, I don't want to work with employer groups and I don't want to work with anybody besides my patient to pay me directly because they fully, buy into this middle concept. And I think it's important to just kind of spend a minute saying this out loud, because as I just went through this whole history of like what happened as the third party system became more and more and more and more and more entrenched into how we delivered care, it got to be more and more and more and more cumbersome, and nobody wanted to be in that system. And so here we are starting over again. It's saying like, let's just do cash pay. And then the sort of like sneak in of like, but maybe some third party payers are okay, right? So I think it's an important thing to sort of sit with and to talk through kind of as clinicians and as people working in this space, that is something we should be aware of. Anyway, so looking back, so DPC was started. I have the Blisses here, Garrison Bliss, Erica Bliss, who I think get the most the most sort of exposure as being some of the biggest leaders at the beginning of the DPC movement. Their clinic was Q Alliance. They worked a lot with getting legislation passed nationwide to include DPC as not insurance, working with Dr. Eskew, working with the Direct Primary Care Coalition, Jay Keys and whatnot. And also got to the point where the Affordable Care Act was mentioned Direct Primary Care was specifically mentioned in the Affordable Care Act and protected. So kudos to them. So regardless, those who started the movement were the true trailblazers, or were just crazy enough to go out and do something different. This is Dr. Ryan Neuhoffel, and I use the word crazy very intentionally when discussing him, and he's not here to defend himself, so it's not fair. But anyway, his clinic is just down the road in my hometown. If we have time at the end, I could tell you the story of how I met Ryan. It was pretty good. I was in med school, and he was a resident, and he was out of control. But anyway, so these DPC doctors entered into a world that was familiar in a historical sense, right? But it was completely unknown to the modern primary care provider. Their employment and career prospects were such that they thought it was a better path forward to go into direct primary care or to invent direct primary care than to enter into the status quo. So they started a small business. They had to run this small business without any technological support because there was no software at the time that was designed to run a membership model. They had to figure out how to connect their patients with other like-minded vendors, entities, et cetera, who were willing to charge a cash price at a time when this was incredibly foreign. And then they had to keep that small business up and running. And so I think it's interesting when, this is Nick Thompson, this is another Kansan. We're actually technically in Missouri, but I'm a Kansas girl. So I have to highlight my Kansas brethren here. But Nick Thompson is out of Wichita, and I think he's one of, he's just an amazing colleague and kind of talks here about how none of the other practice models would allow me to have the kind of relationships I want to have with patients, to get to know them and invest in them while providing affordable care in a full spectrum practice. And direct primary care did. And so it wasn't just all of those little hurdles that they had to overcome. It was also that they were following, and we spoke about this yesterday afternoon, Molly, myself, and Tasha, about how we just wanted to provide care the way it should be provided. So from the aughts to the present, all of these crazy people have started their own direct primary care practices. The tech has evolved. We now have software that supports us. We now have vendors that want to play in this space. And this, I think I pulled a couple of weeks ago. This is the mapper that I find to be the most authoritative source as to how many DPC practices there are. It's from DPC Frontier. It's Dr. Eskews. The number was 2015 that they had the other day when I pulled that. And that is markedly more. When I started, I think there were 300. And this whole part of the country had none. So we've grown a lot in the last 5 years or so. But here's what I want to talk about today. Where are our specialist friends? Good, yeah, and I know they're here. I should definitely say, I am so happy to see specialists here today. But it's been one of these conversations kind of over time, and I'm going to kind of detail my backstory as to why I think about this. But essentially, finding the specialists in any given metropolitan city who are wholly committed to a transparently priced direct pay service model is super tough. So I mentioned at the start that I work with Sesame. I'm the medical director for Sesame, marketplace again for transparently priced healthcare services. When we started back in 2018, we started here in Kansas City, and the goal was to have a pretty comprehensive marketplace where we could have primary care, but also have all of our specialty colleagues, and the focus was on brick and mortar. Of course, in any metro, and I'm not sure if you guys can speak to this a little bit more in your own personal experience, the more mergers and acquisitions and consolidation, and the more you have these large hospital systems, the less likely they are to play in that sandbox of the direct pay, transparent pricing marketplace. Luckily, here in Kansas City, we have enough competition, we have enough independent practices that we were essentially able to get, at least one specialist in each area that would say, yes, we'll be happy to give you guys a cash price. We hit ENT, GI, cardiology. We never found OBGYN, and there were some other ones that we had a few holes, but essentially we were able to kind of get that set up. And then COVID happened, and the rest is history on that. But regardless, it was a tough battle. We were able to find one specialist in most of the areas, but it was really, really, really tough. And the reasons we experienced were manifold. So usually it would go something like this. We would approach a practice, and the number one barrier that they would express would be that they didn't know how to provide a cash price. They weren't sure what to charge. And so the conversation would go something like this. Like, they would be like, well, we have a charge list. And I'd be like, right, but nobody actually pays the charge list price. And then they would be like, yeah, right, but those are our prices. Like, if you want our prices, these are our prices. And then we'd be like, okay, so what if you had a patient who was willing to pay up front, they would pay in full, and you wouldn't have to chase after them, and there would be no accounts receivable, and you would get all of, it's a great patient, da-da-da-da, and they would just be like, and then we'd be like, and for that you would probably charge a little bit less because you're not having to staff up this whole team of collecting, and then they'd be like, yeah, I don't know. And you're like, oh. And so they'd think about it, and they'd be like, well, we don't know what the charges are going to be prior to the visit. Like, okay, fair. Visits could be like, right, like I'm a physician. I'm like, I know this. You don't necessarily know what you're going to bill at the beginning in the current model. So they'd be like, all right, visits can be complex, whatever. It's like, so why don't you you're smart people. Like, why don't you do maybe a 12-month and 18-month look back? Take your top E&M codes, your established patient, new patient. We're not asking for rocket science here. Take an average, see how much you actually get reimbursed. First of all, I don't think anybody could answer that. But see how much you actually get reimbursed. Maybe do your top procedures, and just take an average over the last 12 to 18 months. I don't know. I'm not sure we could do that. These are smart people. These are people running healthcare practices. And then, the argument that it would eventually happen would be they would just say something like, even if we could do that, that would change our workflow completely. And I'm like, out of everything you've said, that is probably the excuse that makes the most sense, is that you just don't want to change your workflow. I get that. And like we talked about yesterday, change management is hard. Anyway, in the end, what came out of this was that they just didn't really have any economic incentive to change. They didn't want to do the work. It was going to be hard. They didn't think the cash pay patient was that reliable. And some practices were so blunt as to say, we don't want to take care of poor people because they're unreliable, because they equated the cash pay patient with a poor patient. And I was like, this is infuriating. Anyway, so given our struggles kind of to recruit, both with my work in Sesame, but also in my direct primary care practice, we tried to make these partnerships and we tried to make them work. So I reached out to Dr. Smith in preparation for this talk, because obviously he's hosting us this weekend, and has had a successful practice in this model. And he shared the history of kind of how SEO evolved to be what it is. And I am embarrassed to admit that it was a new story for me. I'm sorry if you guys have heard it before, but I'm going to share it on his behalf. But essentially, they opened the surgery center in the 90s. It was physician-owned, fully owned. And they originally they were getting insurance contracts, and they had negotiated with all these different insurers, and ended up being out of network for every single one of the insurers that they tried to get in network with, which they thought of as, at the time, as a death sentence. And so they took this crummy position that they were in and essentially said, well, how can we turn this to our competitive advantage? Like what can we do to make ourselves stand out? And so what they decided to do was that regardless of the patient's insurance status, they would basically do a consultation with every patient and give them a quoted price prior to their procedure. So they would take into account, what is your deductible, your coinsurance, all that. Highly manual process, highly individualized, but they would do this for each patient. And word on the street got out that people could predict the costs, that their prices were transparent in a sense, even if they were out of network. And sometimes they're more competitive than the in-network hospitals there in their community. So this went on for a while. And as Dr. Smith tells it, the insurers didn't like this because they almost, due to the way that the contract was phrased, they almost qualified to be in-network. And so all of a sudden they changed the rules of the game. And they said, no, in order to use your out-of-network benefits, you have to max out your in-network deductible. So like a deductible stacking. So this is about 10 years after they started. So essentially the rules of the game changed underneath them again. And he was so frustrated by this because it was like another death blow of I was trying to do right and we got our business up and running. Now you're changing the rules, da, da, da. So this is in the early 2000s that happened. And it took him another 4 years, he said, to actually figure out that the entire value that they were providing for people from a marketing and a business sense was the transparency and pricing. And so at about 2009, they started publishing their cash prices on their website. And of course, you all know that the rest is history. And so what's interesting is that as I was talking about him, or as I was talking to him, I was just like, okay, great. Like, so how do we get more specialists to do this? How do we, get people to kind of see like you're doing it, you're successful, et cetera. And the way that he phrased it was that he doesn't think that specialists are going to make it en masse. And this is why I want to stop talking so I can hear from you guys. But specialists are not going to change en masse unless there's so much pain in the system that they are better off outside of it. So like primary care doctors, like we're done. Like we are so screwed in the insurance-based system that in mass we're just like, nope, DPC makes sense. Like we can't take insurance, blah, blah, blah. We drank the Kool-Aid. For a lot of specialty reimbursement, there's enough revenue there that it's not painful. Like you can kind of hire out some staff, especially with some procedure-based specialties. You can hire out staff to deal with the BS and to deal with the bureaucracy and all that stuff that's in that snowball running down the hill. But that just wasn't there for primary care anymore. It disappeared, and so insurance was just no longer valuable. So that was kind of his point, was he was like, it has to be so painful that specialists are quitting or going to a non-insurance model. And you heard that from Dr. Tasha, who was sitting next to me on the couch yesterday. So anyway, so that's kind of the extent of what I was going to talk about today. And I hope that we have time. I think I went through that pretty quickly. What time is it? 8:29. And we started like 5-10 minutes late, maybe? Okay. So like 5-10 minutes maybe for some discussion. Because I don't have any like, oh, here's a microphone.
I was just going to say, I think the hospital privileges are a stumbling block. That's what I hear from my specialty colleagues, is that they have to be credentialed in order to have their hospital privileges. So I don't know if you have ideas.
In other words, being independent, outpatient, not associated.
Even if they are independent, even if their practice is independent, they still need hospital privileges for a lot of the procedures and stuff that they do. So, I mean, Keith solved that by having his own freestanding surgical center, but that's harder to do in a lot of states because of like the certificate of need laws and so forth.
Plus the sheer cost of building a gazillion-dollar facility.
Specialists need other testing facilities. Proceduralists need places to do their procedures. It's not like family care. You can literally have your own office, buy your own supplies, and do everything. So there's a lot more moving pieces, and it's not as simple as saying that you want to get out and do it. You have to persuade a lot of other people.
Will you introduce yourself? You raised your head when you said you were a specialist.
Yeah, I'm a general surgeon. We're starting a surgery center up in Idaho.
Yay!
Sorry, you can send your patients up to us.
Yay!
Oklahoma may be closer, but...
Whatever. People travel. It's interesting. To your point on family physicians just starting anywhere, one of the physicians here in the Kansas City area started his practice in Panera. That's where he would see his because he didn't have a brick and mortar spot. He didn't want to see them at their house or his, so he would see them at a coffee shop, which totally weirded me out, but it worked for him. He's now thriving. So yeah, you're probably not going to operate in Panera. That would be weird. No. Okay. Yeah, right. Just lay him out of the steel. Any other specialists have context or want to share their experience as to maybe hurdles you've overcome? And introduce yourself too, kind of weird.
So I'm dermatology, ex-internist also, but I opened a direct pay dermatology practice in 2011. And you're right, you know, in dermatology, you have a lot of equipment, but you can have it in an office. But the pain point. So I had a bad payer mix, and I was in a group I liked. And yeah, you do. I think you're exactly right about exiting. And then it needs a few bold people. And the other thing is that you learn from your patients. If you take the time to interact with them as a human being, and they tell you if they are a high deductible or a cash pay, and you start learning from them that there's a niche there. And also people who can't get good care. They actually want to see a doctor. They actually want more than one question answered or discussed. So there's a big niche there, and you're not really aware of it when you're in the system until you start learning from your patients. So,
how has your practice grown over the years without? Because I think another criticism or concern is like that funnel, the marketing funnels that insurance provides, or people just come through your door constantly. Did you have to learn how to market your business? Or
well,
flip signs on the corner.
We were in Oregon, my husband and I, and he's the entrepreneur, and we owned our own building. But no, see, we knew a lot of people around town. Tons of doctors said, this will never work. Nobody will come see her. And he loves marketing. He had all sorts of plans for me to go and talk to various groups and things. And my schedule was full in 2 months.
Congrats. That's awesome. Okay.
Yeah.
Any other context or experience anybody wants to share about successes or failures?
So I'm curious about, you were bringing up specifically about OB-GYNs and you were making inroads and then COVID hit. So I'm chairman of the medical board at a nonprofit that primarily in Fort Worth that is OB-GYN and family practice. But the crux of it was first innovative care for women that are being underserved in general. So my goal is to try and convince them that what they're having to go through and our difficulty within the nonprofit is we're not getting compensated we're not getting 100%, 120%, we're not getting 100%. And so it's a struggle to get them what they deserve, right? And being at this conference last year, I understand the way is the DPC route, but one of the things I have to do as chairman of the medical board is to convince them. But I don't think that's going to happen unless I do it myself. So I create something. I'm a pediatric ER physician, so either in general pediatrics or creating an urgent care DPC within the environment of not the nonprofit, but for them to see. Because I don't know how to overcome when you're in the matrix, but you can't see that you're in the matrix. I can't get beyond that. It's just there's a great deal of fear and just disbelief.
Yeah, I think that I'm not a psychologist, but I think that fear is a very powerful motivating emotion, and I think that as physicians, we're very conservative. We've worked really hard and really long, and then put in the financial risk of medical school and whatnot. And you sort of look at employment, or you look, one way, and you say, well, I've got somebody giving me a W-2 and holding me hostage, but it's secure, which that's not true, by the way. But anyway, but you see that, and then you see kind of going out on a limb into a new model. So to your point, I think the more examples you see, and God bless you if you're the one that has to spearhead it and do it yourself, but the more examples you see, you saw was that my last slide? How many places we have, this is exploding, and it's that adoption curve that we looked at yesterday of the innovators, early adopters, and kind of DPC is kind of hitting that peak where we have more and more people because it feels more comfortable. I don't know where we're at on the specialist curve.
Just to expand on that point, our medical education system is also largely responsible for this because all the specialists, even more than the primary care fields, the specialists train in large systems, in large hospitals, and that's all you ever know. And then on top of that, you add the rapidly accelerating debt burden that everybody's coming out with. So we need conservative schools to train people to actually practice good business and medicine. We need more training programs in smaller hospitals, and then we need to reform the financial side of medical education to make it possible for people to
Problem solved. Go.
No, is that easy?
I have a question. If it's not time, we can talk later. But how do you set boundaries with your patients in that kind of a relationship? So for some context, I'm a medical student who's thinking of setting up shop in direct care. And I hear on one side, DPC docs talking about how they did it because they have so much more time to spend with their family. And as someone who's, in that stage, that sounds appealing. But on the other side, I hear about how what's great about my DPC doc is I called them on Christmas morning and they took care of me, or I called them on Saturday.
I hate it when the brokers are like, you could just text them and they'll give you antibiotics in 5 minutes. And I'm like,
yeah. So how do you manage those kinds of boundaries of, you want to be there for your patient all the time, but also you need to take care of your own family and have a life?
That's on you. That is not on you like for the whole industry, but for yourself. Yeah, you have to train them and then you have to train yourself. And training yourself is probably the harder part. And so clearly delineate and get a good mentor who you feel like is actually doing a good job of that, not somebody who talks about it a lot, because the people who talk about it a lot tend to be the ones who are the worst at it. But somebody who's actually like living that good balance and figure out kind of their MO and then hold yourself to it is truly the hardest part, I think.
And on the medical education note, real brief, things have gotten really bad in medical schools. I can attest to that. And I would just encourage all of you to reach out to your medical schools. You know, I go to these events and I hear a lot of doctors tell a sob story of how like they found direct primary care because they just hit rock bottom and we're at the end of the road. And just for me, I'm really passionate about, well, can we save a lot of people a lot of suffering by just reaching them before they are trapped in a system with and we don't learn about DPC or any of these things in medical school. We don't even learn basic finance, economics, business, debt management, anything at all. And so really just you can make a difference by simply being a mentor to medical students, reaching out to them, and we really need that.
Here, here. Yeah, the DPC Alliance has a little bit of a residents and students arm. I can't speak with authority on it because I don't know much about it.
So to the med students, so we have med students rotate with us at NextAir Healthcare. So we're in Colorado, and if you'd like to come out, we'd love to have you. We also have residents rotate with us as well. And then the American Academy of Family Physicians has an annual conference, and typically DPC presents at that. And there's also the American Academy of Family Physicians DPC Summit, which is happening in Minneapolis here in June. Yeah, feel free. There's a lot of us that are happy to have them come through, and then hopefully we can hire them thereafter or help them start their own business. To the factor of, you know, your patients bug you all the time, and a lot of us older doctors have been around in the fee-for-service world and the DPC world, so I carry a panel of about 900 members myself, and they're super respectful. And we have an app called Spruce. So Monday through Friday, 8 to 5, patients can reach out to us and schedule appointments. They can also, if they have urgent issues, they can message us through Spruce or message us directly on the phone, and we get them in same day for that. And we have great staff that helps out with that. After 5 p.m., if it's urgent, they can reach out to us, and we always have a doctor on call. I can't remember the last time I was pinged after 10 p.m., and I have 900 patients. They're super respectful of our time, and I'm always happy to answer the phone at 2 a.m. That's much different than the old days of some of us older docs. We used to have to go into the hospital and meet our patients and see them at 2 in the morning. So it's just virtual call. It's super easy. The one thing I just would say to my specialist colleagues, there are a lot of people like Dr. Smith, as well as in Colorado, there's Nodora. So Nodora is a ASC, Ambulatory Surgery Center, owned by physicians that we refer to. And then there's companies, and some of them are here, like Savos, as well as Sanos, Dutch Rojas, that will essentially do a great job of connecting employer groups and or people directly to your surgery center, to your dermatology center for direct pay pricing. So kind of think of them almost like you bundle the surgery, but they bundle the people and bring them to you, and then you can have direct pay from the employer. So for example, I just had a patient that had a back fusion at Nodora. You can spend the night there at Nodora Hospital. Her out-of-pocket was $0. $0 copay, $0 out-of-pocket for a fusion, because her employer picked up the whole bill and paid Nodora within a few days or a week or so. So there are entities out there, my point is, that can drive business to your direct specialty practice, because that's, you spend all the money for the equipment, who's going to come in through the doors?
Just ask Panera for a timeshare. It'll be fine.
Do you have a question? We'll do this as the last question.
Not really a question. So I have third-year medical students rotating through my practice. Every 6 weeks I get a new student.
And tell me more about yourself, your practice.
I'm just south of Boston. I've been in DPC practice for 6 years now. I'm assistant professor at Tufts, and so I have Tufts students rotating through my practice. So over the past probably couple of years, there's been at least 3 students who were thinking about going into specialty practice, and because of their experience in my office, have decided to go into primary care.
That's awesome.
And as far as patients calling you, I've got a panel of almost 700 patients, and I don't remember ever getting called in the middle of the night. So, but my patients are able to get in to see me same day.
Thank you guys for a good conversation. Keep the conversation going. Trade business cards, etc. I think we're going to get kicked out because something else is happening after this.
Yeah, we go back up to the tutor room.
Okay. So that's where we all go. But yes, keep the conversation going. Thank you for listening. Thanks for paying attention today. And I appreciate all you guys, what you do.